Hello, everyone, and welcome to today's live broadcast, Molecular Testing for Hereditary Familial Prostate Cancer and for Risk Assessment in Localized Disease, presented by Dr. Judd Moul, the James H. Semans Professor of Surgery in the Division of Urologic Surgery, the Director of the Duke Prostate Center at the Duke Cancer Institute at Duke University Medical Center. I'm Dr. Susie Valdez of LabRoots, and I'll be your moderator for today's event. We're delighted to bring you this educational web seminar presented by LabRoots. LabRoots is a leading scientific social networking website and producer of educational virtual events and webinars. Before we begin, I'd like to remind everyone at this event that it is interactive. We encourage you to participate by submitting as many questions as you want at any time you want during the presentation. Just click on the Ask a Question box located on the far left of your screen and type your questions into the drop-down box that appear on the screen. We'll answer as many questions as we have time for at the end of the presentation. If you have any trouble seeing or hearing the presentation, please click on the Help Desk button located in the promotional board at the bottom center of your screen, or use that Ask a Question box and let us know you're having a problem. This presentation is educational and thus offers continuing education credits. Please click on the Continuing Education Credits tab located on the top right-hand corner of your presentation window and follow the process for obtaining those credits. Without further ado, please join me in welcoming our presenter today, Dr. Judd Moul. I will now turn the presentation over to him. Welcome, sir.
It's a sincere pleasure to be with you this afternoon, and I want to thank LabRoots for inviting me to present this continuing medical education program. And we're going to be talking about prostate cancer and the hot topic of hereditary and molecular testing. My disclosures, I have been a speaker in the past for Myriad Genetics, Genomic Health, and Genome DX. So one of the fundamental questions all of us who take care of patients with cancer and those of us who do research in cancer, what causes cancer? And certainly we see this group of men sitting outside, four guys, older guys. They would be a typical clinic of mine in men with prostate cancer or men with enlarged prostate. And what makes three of those guys be okay and one of those men develop prostate cancer? Certainly, we know about environmental factors. You see the picture here of someone smoking. Fortunately, smoking is not one of the major risks for prostate cancer, but certainly other environmental factors such as diet could be a risk factor for prostate cancer. And then you see a cartoon here of DNA. And the other key issue is how much of cancer is related to genetics. So genetics are a major cause of cancer, as you see in this headline. Genomic testing issues in the era of precision medicine, meaning we're moving towards more individualized care of patients with all types of cancer. And certainly this is the case in prostate cancer as well. And another headline, personalized genomic-based care could mean a paradigm shift, that we've been treating most of our patients based on just stage and grade alone. And we're moving into an era where individual genetics of tumors are going to direct cancer care, and that's going to be the case with all cancers, including prostate cancer. Let's talk a little bit about the basics. We see here somatic versus germline mutations. So somatic mutations are gene mutations or alterations that are present in the tumor itself. They would be tested using tumor tissue and looking for genetic alterations. Compare that to germline mutation, where a mutation occurs in the DNA that's inherited. And we'll talk about that a little bit further. And that would form the basis for development of hereditary cancer. So all cancer is genetic, but not all cancer is hereditary. So that's an important distinction. And if we go back to our basic biology, we all have two copies of normal genes on our two sets of chromosomes. And classically, when we think about genetics and cancer, one would have one damaged gene and one normal gene, and the patient's okay. But then when two damaged genes occur, a tumor develops. In hereditary cancer, one of the damaged genes is inherited. Therefore, it takes less effort or less random events to cause that second damage, and then a tumor develops. So if you're born with one altered gene, instead of having two mutations develop in two alleles, you only need one. And this is why these hereditary mutations or these inherited genetic defects lead to a higher risk of cancer. And if we evaluate hereditary cancer risk, and this is not just for prostate cancer, but pretty much all the cancers we deal with, most of the time with regard to cancer, it's sporadic, meaning we cannot identify a family history. We can't identify a family that's prone to cancer. On the other hand, there are patients who report a family history of cancer, and that may or may not increase their risk of cancer and may or may not increase their risk of harboring a hereditary mutation that leads to increased cancer. And then we have the true hereditary cancer, and certain ancestries, such as the Ashkenazi Jewish ancestry, may be at increased risk of harboring hereditary cancer risk. Who are these? Who are people that were concerned about hereditary cancer? Well, think of multiple cancers in a family, cancers that occur in multiple family members at a young age, and rare cancers. So when we're now being taught to take a better family history, we need to think about those factors and at least take that history, and a red flag should go up in our minds when we're dealing with patients who may have multiple family members with cancer, particularly multiple young family members with cancer or unusual cancers. Now, at the bottom of this slide, there's a quote here primarily targeted to gynecologists, telling them that they need to take these good family histories to identify familial cancers. Why is it? And this was dated 2015. Well, as we know, breast cancer is not, it commonly has BRCA mutations. And so that's been the hallmark disease, and we'll talk about that in a minute. But now we're talking about this among urologists because we're identifying more prostate cancers that are thought to be due to hereditary cancer. So let's step back a little bit and compare tumor testing versus germline testing. So tumor testing is basically when you take a piece of a tumor or a cancer and you're looking for genetic alterations or mutations in the tumor itself. And later on in the presentation, we're going to be talking about a number of commercially available molecular genetic tests that can be done on tumor tissue. So that's the second half of this talk. But before we get to that, we're also going to be talking about germline testing. That's basically testing the blood and the saliva, looking at our constitutional DNA, or what we're born with regard to our DNA in all cells, and trying to determine if we inherited a mutation in one of these cancer-prone genes. So again, the testing is done on blood or saliva if you're looking at germline testing, or tumor tissue if you're testing for somatic mutations. The classic hereditary cancer gene is the BRCA family, BRCA1 and BRCA2. And this is a classic autosomal dominant hereditary gene. And I'll talk about it a little bit more in a minute, but the BRCA family are in what they call the DNA repair family. So these BRCA1 and BRCA2 encode for proteins that help our body cells repair itself from DNA damage. So you can understand if this gene is mutated, causing a messed up BRCA protein that then doesn't repair a person's DNA properly, it's going to lead to an excess risk for cancer. And so BRCA1 and BRCA2, the classic is hereditary breast and ovarian cancer. And this also leads to increased risk of male breast cancer. But the core cancer risk, meaning what are the most common cancers that form in people and who inherit a BRCA mutation, and it would be breast, ovarian, pancreatic, prostate, and melanoma. So those 5 cancers are more commonly found in people who have a BRCA 1 or 2 mutation. Again, it's an autosomal dominant inheritance, and the prevalence in the population is estimated to be 1 in 300 to 1 in 500. So it's not that rare. And this just shows cancer risk associated with BRCA1 and BRCA2 mutations. So you see right here on the far left-hand side of the slide, female breast cancer. General population 7.3, but if a female inherits a BRCA1 or 2 mutation, her risk of breast cancer is close to 90%. It's very high. Now, I boxed here prostate cancer and male breast cancer, the diseases that I might see as a urologist, particularly prostate cancer, and it's not as pronounced as with breast cancer, but in the general population, lifetime risk of prostate cancer is 8.2, but that goes up to a 20% risk with a BRCA mutation. So basically, looking at it another way, about 20, there's a much higher risk of a patient who inherits a BRCA 1 or 2 mutation to develop prostate cancer over their lifetime, and similar with male breast cancer. And this just shows a cartoon showing BRCA1 and BRCA2 proteins in this DNA repair pathway. So in all of our cells, we have this machinery, this complex that our bodies are undergoing DNA damage all the time and are exposed to DNA damage, but most of the time this mechanism repairs that DNA damage and prevents us from going on to develop cancers due to DNA damage. However, if BRCA1, BRCA2, or some of these other genes like ATM, CHEK1, CHEK2, ATR, etc., if these are mutated, or if a patient inherits a mutation that messes these proteins up, then this machinery doesn't work properly, the DNA damage gets through and increases the risk of cancer. So that's why patients who inherit these DNA repair gene alteration, who inherit something that messes up this repair mechanism, are at increased risk for cancer. And so, as a urologist, we see a lot of patients, a lot of males who have elevated PSA, enlarged prostate, kidney stones, and all kinds of diseases of the male urinary tract. But to put this in perspective, in a large community urology practice, who, for example, may be diagnosing 1,000 new prostate cancer cases per year, anywhere from 50 to 115 patients in that practice could harbor a mutation in one of these genes. If you say that practice is caring for 5,000 prostate cancer survivors collectively, there's anywhere from 230 to 590 patients in that single practice that may have hereditary cancer gene mutation. And then if you just look at advanced prostate cancer, where these gene mutations, these hereditary cancer mutations may be more common, in a practice who has 250 patients with advanced prostate cancer, 25 to 60 patients or more could have a mutation. So it's not rare. It's something that we need to think about and potentially do better testing for. Now, the NCCN guidelines circa 2017 address this a little bit. They basically say that for prostate cancer, we should take a good family history. And in this box, it talks about trying to identify patients who may have a brother or father or multiple family members diagnosed with prostate cancer at age less than 60 years of age. Those patients might have a germline DNA repair gene abnormality, especially BRCA2 mutation, or they could have Lynch syndrome, which would be germline mutations in some of the mismatch repair genes. So the key teaching point is trying to teach us as urologists or as clinicians who care for men with prostate cancer, or doctors who see men with elevated PSA levels, to take this better family history and at least be thinking about the possibility of hereditary cancer syndromes. In the current guidelines that include genetic testing are the NCCN high-risk breast and ovarian guidelines, which does make prostate cancer screening recommendations based on BRCA mutation status. For example, if they identify a family who has BRCA mutations, the males who may have a BRCA mutation should start prostate cancer screening at age 45. Last year it was 40, but I think the key teaching point is that in BRCA families or in families who have these mutations, they are at increased risk for the males developing prostate cancer, and those men need to be placed on some type of focused testing program for prostate cancer. Population screening for prostate cancer in the general population remains controversial, but I think there's less controversy surrounding cancer-prone families and focused screening in those individuals. And this just shows, again, the 2017 BRCA-related breast and ovarian cancer syndrome guidelines, as I mentioned earlier. So let's just present an illustrative case. This is David. David is a 60-year-old man who was diagnosed with Gleason 3 + 4 = 7 prostate cancer. He had a PSA of 4.8, no family history of prostate cancer, and he was placed on active surveillance. Now, for those on the line who are joining us today who do not do prostate cancer every day, this just is a typical patient we would see. He has middle-grade prostate cancer, low volume disease, fairly low PSA level, and active surveillance, which simply means that we're monitoring the cancer closely and not intervening immediately with surgery or radiation. This active surveillance is really gaining in popularity around the United States and around the world. And so you see on this, this is David here in yellow. So 2 years later, David's PSA has risen to 9.5. He undergoes bone scan and CAT scan just to make sure there's no metastasis. These are all negative. And so he switches from active surveillance to undergoing a radical prostatectomy. And unfortunately, he has positive pelvic lymph nodes, which is pretty uncommon, but he has positive nodes, and he is placed on androgen deprivation therapy. His Gleason score in the radical prostatectomy, he was upgraded to Gleason 8, which is considered high-grade cancer. After the surgery, his PSA drops to 0, indicating that he is currently at this point disease-free. But 4 years later, his PSA remains 0, but he's developed low back pain, and his bone scan was suggestive of metastatic disease. Interestingly, a physical exam shows a right breast mass, which ends up being biopsy-proven invasive ductal carcinoma. So this gentleman had prostate cancer and now has male breast cancer. So there should be a red flag that goes up. He has a mastectomy, spine radiation, and tamoxifen. But a red flag didn't necessarily go up at this point in time until David's sister was diagnosed with breast cancer. Well, the breast surgeons and the gynecologists were more on the ball at that point in time, at least, than the urologist or the doctors who were caring for David with prostate cancer. So they recommend hereditary cancer testing. And lo and behold, David's sister has a mutation in BRCA2. And then they go back and get a better family history. Turns out that there's, in the generation prior to David and his sister, the mother had breast cancer at age 44. Another sister, Anne, had melanoma at 45. And if we go back yet another generation, there was a grandfather who died at age 62 of pancreatic cancer. So there's actually a fairly robust family history here. So David, unfortunately, was not tested. Had David been tested for BRCA2, it would have been positive, and we would have found out that David was not a good candidate for active surveillance, meaning he would have had this BRCA mutation detected. And we know now that patients with prostate cancer who have a BRCA mutation may have more serious cancer. It would have been contraindicated to place him on active surveillance. And so, we see this headline, inherited mutation, increased risk for lethal prostate cancer. And that's referring to this study from Castro et al. This was published in JCO in 2013. And the key teaching point is that patients with hereditary BRCA mutations, especially BRCA2, who present with prostate cancer, have more aggressive, more risk of advanced disease. And that's further illustrated on this slide. Well, actually, let me go back for a minute. That's illustrated on this slide, showing that the disease-free survival, overall survival, localized disease probability is less in patients who have a BRCA mutation compared to controls. So patients who are non-carriers versus BRCA mutation carriers, the patients with BRCA mutations have a worse prognosis. So again, the key teaching point, active surveillance would have been totally irresponsible for this patient with a BRCA mutation. But at that time, again, this was a couple years ago, the medical community was not keyed in on this. This is all new information over the last year or two, so it's hard to beat up on the doctors from a couple years ago because they didn't know. But again, now we would really want to take a good family history and try to ascertain that family history before we put this gentleman on active surveillance. This slide just talks about the fact that olaparib, one of the PARP inhibitors, oral therapy, is used to treat patients who have BRCA1 and BRCA mutations. So whereas PARP inhibitors would not be useful in the general prostate cancer population, patients without these mutations, specifically in prostate cancer patients or patients with other cancers where there is a BRCA mutation, multiple studies now have determined that the PARP inhibitors are a very effective therapy. And I just wanted to make sure I put that slide in here now because these PARP inhibitors are starting to come into play in prostate cancer in both the situation where a patient would have a germline BRCA mutation, but also in tumor testing where a BRCA mutation may be present somatically, indicating that that individual tumor had mutated and had a BRCA mutation. So back to David and the summary and the key points. If David were to present with his prostate cancer today, he would clearly meet criteria for genetic testing and his BRCA2 mutation could be factored into management. One, active surveillance would have been ill-advised or contraindicated. Two, his elevated risk for breast cancer would be known and he would have been under closer surveillance, likely allowing him to be diagnosed at an earlier stage. And three, the other BRCA2 carriers in the family would likely have been identified and his sister and daughter would have options for avoiding breast and other cancers. So this is a real case where the patient had a pretty strong family history, but it wasn't known by the healthcare providers when they treated David. Now, let me switch gears and talk specifically about patients who present with metastatic prostate cancer. In other words, this would be a patient who, when he first came to attention with prostate cancer, it had already been metastatic. This is not necessarily the guy who had early stage disease, followed, and then later developed metastatic prostate cancer. This is for the guy who presents de novo with metastatic prostate cancer to the emergency room, the clinic, or the hospital. And this is a paper from Pritchard and Associates from the New England Journal of Medicine from 2016, which I think is a real hallmark paper, a real classic, because this paper shows that about 12% of patients who present with newly diagnosed metastatic prostate cancer have a DNA repair gene mutation, a hereditary cancer mutation. So this was striking in that 12% of men with metastatic prostate cancer actually have hereditary prostate cancer. Pretty amazing. And almost half of these were BRCA2 mutations. Again, if you look at the overall group of about 12%, of this 12%, again, 44% of the time it was a BRCA mutation, BRCA2, 13% of the time it was an ATM, 12% it was CHEK2, and then a smaller percent BRCA1. Now, again, all of these genes are in this DNA repair pathway. These are all cases where that DNA repair machinery was messed up because the patients inherited a mutation that caused a disruption in protein function of one of those genes in that repair cascade. Now, this is a slide that shows a picture of a consensus panel that was held in March of 2017, about a year ago, at my alma mater, Jefferson Medical College in Philadelphia. And I was blessed to be part of this panel. And this was specifically convened to try to form the basis for what urologists, medical oncologists, and radiation oncologists should do with regard to hereditary cancer testing in the specific setting of prostate cancer or prostate disease. And the outcome of this consensus was published just in the last month or two in Journal of Clinical Oncology. So for those who are on this program today, you can go to JCO early 2018 and the paper that was published outlining the findings of this panel. So what is our status at Duke University where I work? Well, we are doing germline testing in nearly all men with metastatic prostate cancer. There are multiple commercial assays available, and I'm not here to endorse one over the other, but right now we're primarily using the Invitae test, which is a 44-gene saliva or spit test, or in some cases using the color test. Many insurers now cover this testing given the recent NCCN guideline updates. If positive, we refer to the hereditary cancer clinic, and we have kits in the clinic, and our nurses are trained to do this in about 10 minutes. Now let's switch gears and spend the remaining time we have talking about somatic mutations. And remember, a somatic mutation is a mutation in a gene that occurs in the tissue, not in the germline, but in tissue such as the tumor tissue of a patient who has cancer. Again, we talked about germline mutations earlier. And we know, again, with looking at these somatic mutations, about 3/4 of men with localized prostate cancer harbor at least one mutation if you interrogate their tumor. Again, this is looking at the tumor tissue and looking for various molecular alterations. In this particular study of over 300 samples, 19% of the time it was DNA repair genes, 25% of the time it was in the RAS or PI3K pathway. But again, overall, about 3/4 of the patients had some molecular alteration. In metastatic castrate-resistant prostate cancer, it was even higher. Now, for those, again, on the program today who do not do metastatic prostate cancer or do prostate cancer work primarily, metastatic castrate-resistant prostate cancer is the most far advanced stage of prostate cancer. And that is the stage that, again, is the most advanced. Many times those patients have multiple areas of metastasis, and those cancers are progressing despite prior hormonal therapy. But in this case, a lot of the time you can find clinically actionable genetic mutations. And theoretically, in the future, these mutations could be targeted to come up with novel therapeutics. And even more exciting and cool is the idea of being able to measure these molecular alterations in circulating tumor cells. And the technology has been getting better and better. And this is being used in other cancers aside from prostate cancer. But this headline just goes to show that this technology is advancing. And theoretically, one day, all patients with castrate-resistant or advanced prostate cancer may be able to have their tumor tissue interrogated looking at circulating tumor cells. We're not quite there yet, but that's where the field is moving. And this headline, new prostate cancer subtypes may predict progression-free survival. In other words, the idea of the future would be to do that novel testing of circulating tumor cells or of tumor tissue, and to base therapeutics more on the molecular aspects than on classic traditional aspects of cancer stage and grade. So in the last group of slides, I'm just going to talk about some of the commercially available molecular genetic tests that can be done on tumor tissue and of prostate cancer tumor tissue. And we're going to break that down into commercial molecular tests that are done on the prostate biopsy tissue, where a gentleman is diagnosed with prostate cancer through needle biopsy, and the needle biopsy cancer cells are tested using commercial assays. And there are two that we're going to focus on, Myriad Prolaris, and the other one is Genomic Health Oncotype GPS. And then we're going to also, at the end, just mention Decipher, or the by Genome DX, which is interrogating radical prostatectomy tissue. And so what is the status at my institution? Again, genetic testing at the Duke Prostate Center and our Duke Cancer Institute. Well, like many major institutions, we have a committee, a diagnostic technology committee, that is a multidisciplinary committee that must approve all send-out molecular genetic tests. Again, when we say send-out, these are tests that are commercially done in standalone labs that are not done in our own hospital laboratory department. So that's why we call them send-out tests. And so Myriad Prolaris was approved back in December of 2012. So we've had, that's been around now for about 6 years. The Oncotype GPS was approved in 2014. Decipher post-radical prostatectomy was approved in 2015. So I'm going to spend just a little bit of a few slides on Prolaris, Oncotype, and Decipher. Before I do that, I just want to put in a caveat, or to temper our enthusiasm about these molecular tests. What do the NCCN guidelines say? Well, all of these tests are included in the guidelines with a couple of caveats. Number one, first, no randomized clinical trial has yet assessed the clinical utility of these tests. So in other words, no prospective randomized trials have truly tested these markers similar to the way drugs are tested. Second, no test has been shown to be predictive of prostate cancer-specific outcomes in response to various management strategies. For example, even though we use these tests to help make decisions between active treatment and active surveillance, we don't have any good prospective data with long-term outcomes to know if, for example, if we did this test, patients lived longer than patients who didn't have the test. That's going to take a long time to get that data. And thirdly, and finally, there are no head-to-head comparisons of these assays, particularly when you have two commercial assays, for example, that can be done on prostate biopsy tissue. We're not sure which is better. So with that, let's just spend a couple of slides on Prolaris and Oncotype. So Myriad Prolaris generically is referred to as the CCP gene function test. Obviously, the commercial name is Myriad Prolaris, but if we're referring to this generically, it's CCP gene function test. And the reason it's CCP stands for cell cycle progression genes. So all the genes in this panel are in the cell cycle progression pathway, and there are 31 genes plus 15 housekeeping genes that comprise the assay. The Oncotype is based on 17 genes. These are spread out in various cellular pathways, and of the 17 genes, 12 are active, and 5 of these genes are considered housekeeping genes. If we do a comparison, both of these commercially available molecular genetic assays are RNA expression panels. So they're measuring upregulation and downregulation of these genes in comparison to the housekeeping genes in the assays. And the upregulation and downregulation pattern makes up a proprietary score, which measures the aggressiveness or non-aggressiveness of the cancer. And both of these can be done on prostate biopsy tissue. The Myriad Prolaris, in addition, can be commercially done on radical prostatectomy tissue, and the Prolaris can be ordered on all grades of cancer, whereas the Oncotype test is more limited to newly diagnosed men with low to intermediate risk prostate cancer, Gleason 6 or low volume Gleason 7, who have had a biopsy within the past 12 months. So on-label use would be a little bit more restrictive for the genomic health test. The limitations of both Prolaris and Oncotype is that neither have been prospectively validated in an active surveillance population. In other words, the most common use for these tests is to get a better grip on the patient's individual tumor aggressiveness. And using that information, it can help the patient and the doctor make a decision if the patient should be monitored under active surveillance or have immediate surgery or radiation. And so even though these tests are used in that type of clinical situation, we really have not had a prospectively validated study specifically in active surveillance with long-term follow-up to really know the true benefit of these tests. It is unclear which of the two tests is better. The tests are fairly costly, $3,000 to $3,500, but they are covered by Medicare, and many private insurance plans now cover these tests. And then also how the information is presented to the patient is not standardized, and physician biases and patient wishes will invariably affect treatment decisions, and they're not globally available. So with those caveats, though, these tests are now fairly commonly used by urologists with early stage prostate cancer patients, especially when they're trying to make decisions between active treatment and active surveillance. The final thing I'll mention is the Decipher test. And the Decipher test is done on radical prostatectomy archival tissue. It's a multiplex gene chip technology, and it's a 22-gene genomic classifier test. So if you go to the literature and you want to use the generic term for Decipher, in the literature, this is referred to the prostate genomic classifier test. The test is Medicare reimbursed. It can be ordered on Medicare patients up to 4 years post-radical prostatectomy, and the indication for the test is adverse pathology, meaning the patient on surgical pathology would have positive surgical margins or extracapsular extension or seminal vesicle invasion or having adverse pathology. Now, if the patient has organ-confined disease, early stage organ-confined disease, and does not have any adverse pathology, the test is not indicated and not covered by Medicare. And so this cartoon just shows where it's positioned. This is a test done after radical prostatectomy when you have the surgical pathology specimen and you send a representative sample of that tissue to the Decipher laboratory in California. And the idea is to use this test for the patient and the doctor to make better clinical decisions about possible adjuvant therapy or salvage therapy that might be needed after the surgery to help provide a better long-term cure rate. This is the sample report, and it places patients into a low-risk, average-risk, or high-risk group post-prostatectomy and provides the patient's relative risk of metastasis and then compares that to a control population. And you see this headline, genomic testing predicts radiotherapy benefit after prostatectomy. This is referring to a nice study that was more recently published in Journal of Clinical Oncology. As you see here in this title slide, genomic classifier identifies men with adverse pathology after radical prostatectomy who benefit from adjuvant radiation therapy. And I'll just give you the highlights of this article. So Decipher high-risk patients who received adjuvant radiation therapy had an 80% reduction in metastasis risk compared to those who received salvage radiation, whereas Decipher low-risk patients showed no difference in metastasis at 5 years for salvage or adjuvant. Let me just step back for a little bit. Again, those people who are on the program today who don't do prostate cancer regularly. In a guy who's had a radical prostatectomy and has adverse pathology, some experts say you should just automatically give that man radiation adjuvantly, meaning just automatically just for the adverse pathology. Other experts say, no, wait, don't give the adjuvant radiation, only give that man radiation if the PSA rises, meaning if the blood marker rises to indicate recurrent disease, and that type of radiation is called salvage radiation. So the key teaching point was that by clinicians using the Decipher test, it helped them make decisions between whether they should pull the trigger for early radiation or simply wait for the PSA to rise and only pull the trigger for radiation with PSA rise. And so this, again, this slide just shows that Decipher might help provide therapy to those patients who are likely to benefit, but to spare other patients unnecessary treatment. So Decipher low-risk patients can be managed safely with observation until their PSA rise. In other words, they're okay to just go ahead and wait and only do radiation if the PSA rises, which is called salvage radiotherapy. But Decipher high-risk patients experience lower rates of metastasis when treated with adjuvant. So if you get a Decipher high-risk in a patient who already has adverse pathology on the radical prostatectomy, this data suggests that you should just go ahead and pull the trigger for radiation early and not wait for the PSA to rise. So this is just an example where a molecular marker test was able to actually help make true important clinical decisions in patients. Now, the caveat here is time will tell if this pans out in the long run. And the naysayers would say that, well, this is all well and good, but we still don't know if patients who had Decipher ultimately live longer than patients who didn't have Decipher, where the doctors just based their decisions on other non-molecular aspects. So again, looks promising, but a true skeptic would say, well, I'm going to wait another decade before I use these things because I want to see if ultimately Decipher improves long-term survival, just like a drug therapy. So that was my my last slide is more of a summary, and then we're going to open up for questions. I think the key teaching points from this presentation is that we really need to understand, not just in prostate cancer, but in all cancers we deal with, the difference between germline versus somatic DNA or molecular testing. That's a critical distinction. We really need to be mindful of hereditary cancers. And again, since I'm a urologist working in the prostate cancer space, me and my colleagues who deal with prostate cancer, we definitely need to be more mindful of thinking about the possibility of hereditary prostate cancer risk. And we talked about those risk factors earlier. We should consider germline DNA testing selectively, again, based on the family history, based on a hunch that the patient may have hereditary cancer syndrome. We talked about BRCA1 and BRCA2 being the classic autosomal dominant gene, DNA repair genes, and that PARP inhibitors are clinically useful as therapeutics in patients with various cancer who harbor BRCA1 and BRCA2 mutations. Then in the last part of the talk, we talked about the commercially available molecular biomarkers. We talked about both Myriad Prolaris and Genomic Health Oncotype GPS being molecular RNA-based assays, RNA-based expression profiles that used biopsy tissue, used archival prostate biopsy tissue to interrogate messenger RNA in these multi-gene expression panels. And primarily these tests are used to help doctors and patients make decisions between whether the patient should go on stay on active surveillance or have active treatment such as surgery or radiation therapy. And finally, we talked about the genomic classifier test, commercially known as Decipher, which uses a gene chip analysis, again, expression panels of various genes, to help us make better decisions post-radical prostatectomy between observation or early radiation or later radiation when the PSA rises. So with that, again, I really want to thank the audience for sticking with me, and we'd now like to, I know there have been questions that have been coming in as I've been giving the talk, so I'll turn it over to our moderator to address some of the questions that have come in during our presentation.
Thank you, Dr. Moul, for that informative presentation. We will now start the live Q&A portion of the webinar. If you have any questions you'd like to ask, please do so now. Just click on the Ask a Question drop-down box located on the far left of your presentation window. Type those questions into the box that appear on the screen and click the Send button. We'll answer as many questions as we have time for. So let's get started and look at our incoming questions from our audience members already. Our first question, Dr. Moul, is for a typical man presenting with prostate cancer, what should doctors and healthcare providers be looking for or asking that might suggest the need for hereditary cancer gene testing?
So that's a really good question, and that hits at the beginning of the talk that, again, we just need to be more mindful of thinking about this, having it in our mind when we take a family history. And we should be asking patients about how many generations, if there have been multiple generations with cancer, the different types of cancer that are present, particularly in brothers, sisters, parents, aunts and uncles, and grandparents. And we really should be thinking about if the patient has several family members with cancers, particularly if those cancers developed in family members less than 60, or a double red flag is if those cancers developed at less than 50. And again, the ones that we really should raise a suspicion is breast cancer in a young age, ovarian cancer, pancreatic cancer, melanoma, colorectal cancer, and prostate cancer, especially if some of those are running together in a family. Again, we presented the David case and the fact that then we went back generations and found that there were young people in that family who had breast cancer, younger people who had pancreatic cancer, young person with melanoma, all in his blood relatives. His case is classic for BRCA mutations. So again, be mindful of it, think about it, and just have a high index of suspicion.
Thank you, Dr. Moul. And should all men who present the metastatic prostate cancer be tested for hereditary prostate cancer genes?
Again, another great question. I think there were definitely people listening in. We really appreciate people's attention on this program, and obviously someone was really listening intently. Yeah, let me make that distinction. So, when we have a prostate cancer clinic, or men with prostate cancer, we have some men who present early, some men who have been compulsive about getting screened, and they get picked up with early stage disease and have no metastasis, and those men, say, go on to surgery or radiation or have active surveillance. In those men who have localized prostate cancer, the risk of those men having hereditary cancer is less than 5%. It's about 4 to 5%. On the other hand, if it's a population of men who just present off the street with metastasis, they show up in the emergency room one day and have bone mets and bone pain, or they, see the doctor for some symptom and lo and behold, they're found to have metastatic disease right from the get-go. Those men have about a 12 or 13% chance of having hereditary cancer. So the key teaching point is, again, if a guy presents with if you see a guy who's de novo with metastatic disease, never had prostate cancer before, bingo, shows up at your clinic and unfortunately has advanced disease right from the start, that guy has again, 12, 13% chance of having hereditary cancer. You could argue that all those men should be offered testing, but particularly if that man with metastatic disease also has a family history, then it's obviously a no-brainer. As I said at Duke, we tend to offer that testing to anybody who presents to our clinic with newly diagnosed metastatic disease, where it was a first-time presentation with prostate cancer with Mets.
Thank you. And what is the active surveillance for prostate cancer?
Yeah, that's another good point. Again, I know folks listening in on the program today are on our webcast. Some of them are likely to be people who are very familiar with prostate cancer, and there may be others on the line who may be laboratory people or people who are just casually aware of prostate cancer but may not really keep up with it. What it is that we've learned over the last 5 years or so that many men with early stage prostate cancer, particularly early stage prostate cancer and low grade prostate cancer with lower PSA levels, may have an indolent, non-aggressive form of prostate cancer that does not require aggressive treatment. And these cancers can be monitored over time without aggressive treatment, and that concept is called active surveillance. And in general, these patients are seen by their urologist or oncologist every 4 to 6 months for PSA testing, prostate exams, and perhaps periodic repeat prostate biopsies or prostate MRIs or other imaging modalities. And so we're actively monitoring that cancer, but we're not immediately recommending surgery or radiation or some aggressive treatment.
Thank you, Dr. Moul. And I do want to also thank our audience members for their great questions coming in and remind them that any questions not answered today will be answered via email. Who is the ideal patient candidate for testing their prostate cancer biopsy specimen with commercial molecular marker tests?
So, well, first off, that's a great point, and I want to make this key teaching point. I really don't believe that we should be doing reflex testing in any case, meaning we should never order a test. A doctor should never order a test unless he or she has a good reason, meaning why order a test if you're not going to use that information to help you make a clinical decision? So first off, and if we're focusing on prostate cancer today, if it's clear to you and your patient what your course of action is based on standard information, in other words, if you know based on the PSA level, based on the regular prostate biopsy, and based on other known clinical factors, you know what the patient wants to do, you know what to do, it's not controversial. I'm not sure you need a molecular test just for the sake of doing it. But many men are confused. Many men have kind of prostate cancer that could go either way. It's not really good, it's not really bad, it's kind of middle of the road. They have early stage disease. They certainly will do surgery if they have to, but surgery has collateral damage in the point of having erectile dysfunction or urinary incontinence. So they're not excited to have surgery or radiation if they don't have to. Anyway, the point is the best candidates currently in prostate cancer would be a gentleman who has early stage prostate cancer and is trying to decide between whether he needs to have that cancer immediately treated or whether he can do active surveillance. And in that setting, either the Myriad Prolaris test that we talked about or the Oncotype GPS test can provide additional information that can help some doctors and some patients make better decisions between active treatment and active surveillance.
I think that you answered partly this next question, which is the best commercial molecular marker test for men who are considering active surveillance for localized prostate cancer?
So another great question, and the honest answer is I don't know. I've had clinical experience with both Myriad Prolaris and Oncotype GPS. Both of the commercial tests in many cases provide me with unique clinical information that in individual patients can help me make better treatment decisions and can help my patient make better decisions. However, I'm not sure which is better. We have no head-to-head comparison between Prolaris and Oncotype. And so I honestly struggle. I have both of the tests available, and I'm not clear which is better. I will say this, that Prolaris has a little bit broader clinical use, meaning it's commercially available to be done in any grade of cancer, whereas the genomic health test is a little more focused, that it's only commercially available for patients with low grade and intermediate grade cancer. So there's some subtle differences there in approved on-label use that, doctors who are on this program today, if they're interested and haven't used these tests before, the best thing to do is contact the company representatives for both companies and just ask them to come in and present on both of them.
Thank you, Dr. Moul. We have time for one more question. Are all men who undergo a radical prostatectomy eligible to have the Decipher molecular test done on their surgical specimen?
No. So the Decipher is, again, the third molecular test that we talked about. And Decipher, the company Genome DX, I might add, also has a biopsy classifier. So there is a commercially available Decipher test for both prostate biopsy and for radical prostatectomy. But for the sake of time on this program today, I only covered the Decipher radical prostatectomy test, and that's the only one that I have a lot of clinical experience with. But in the setting of Decipher for radical prostatectomy tissue, it's only for patients who have adverse pathology, meaning that if a patient has organ-confined disease after radical prostatectomy, his risk of recurrence is so low that you really do not need a molecular classifier to help you make clinical decisions, because you're going to observe that patient regardless. But if the patient has adverse pathology after surgery and you're trying to make a better decision between observing that patient or doing additional radiation, the Decipher test can be very useful, as the JCO article implied, to help make those treatment decisions post-op.
Dr. Moul, thank you again for your presentation today and your important research. Would you like to provide the audience member with any closing remarks before we close today?
Well, I'd just like to again say how honored and delighted I have been to give this presentation. I'm really enthusiastic about this area. I think that, again, this is a great opportunity for doctors who work in the prostate cancer space to become more acquainted with hereditary cancers. I think that these measuring these hereditary and somatic mutations are going to lead to better cancer characterization and better treatments in the future. But again, I just want to thank LabRoots and thank you as the moderator for doing such a great job. And again, it's been an honor and pleasure to be here.
Absolutely, and thank you again, sir. I'd also like to thank LabRoots for making today's educational webcast possible. Before we go, I want to remind audience members that today's webcast will be available for on-demand viewing through July 2018. You'll receive an email from LabRoots letting you know that this webcast will be available for replay. Please share this announcement with your colleagues who may have missed today's live event. That's all for now, and thank you for joining us. We hope to see you again soon. Bye-bye.